Croeso, welcome to this meeting of Powys Teaching Health Board this morning. This is my last meeting chairing the Health Board, so a bit of a sad time, but also an exciting time for us. So I'd like to welcome everybody who's here. Apologies we've had. You will see there on that sheet on the screen. So the names of the independent members and then the exec team, and there are the apologies. So I'd like to press on fairly quickly. Are there any declarations about which we do not already know? No declarations of interest then, thank you. Can we turn then to the minutes of the last meeting, which was held on July the 27th? And these are for approval, and I would like to you to look at them. I'm assuming everybody has read these, and perhaps we can just go through them quickly. Page 2 and 3. Was there anything on the first page? Right, Mez, would you like to come in then? I think you were in attendance that day, were you? You were present,
yeah.
I should say. Yeah,
yes, Chair, I was present.
Right, thank you. Right, 4 and 5, 6, 7. Would you like to come in, Mez?
Hello, hi, yeah. On page 7, it mentions that I brought up flu at the last meeting, and the sentence reads, increase in flu activity of 22-23, and therefore delivery of procurement of flu vaccinations. It should read delivery of flu vaccination rather than procurement of.
Yeah. Thank you.
Thank you.
That's really quite important, isn't it? Especially as it's all over the media at the moment. Thank you very much. Page 8 and 9, 10 and 11. I'm looking for any indications here. And 12, 13 and 14. So can we record that these are an accurate statement of that proceedings at that particular meeting? Everyone happy? Thank you. Matters arising, are there any? No, okay. So that brings us then to the patient story. And Claire Marsden, you're going to present this for us, I understand?
Yep, thank you, Chair.
So would you like to go ahead?
Yeah, thanks. So today I'm really pleased to bring you a story that's been kindly shared with us by Sheila Demery. And I'm going to read the story out in Sheila's words. So Sheila contacted us to say that she's been going to the audiology department in Brecon for about 5 or 6 years now, and they've always been really helpful. And during COVID particularly, they were absolutely stunning. They were always extremely helpful, extremely professional. And any time I phoned and asked for advice or asked for tubes or batteries or whatever I needed, or if they didn't answer the phone, somebody would phone me back. I don't know how they manage it, but they always employ really nice people. They just have a way of knowing how to be helpful, but not condescending. I've worked in the health service a lot myself, and working with the great British public is not easy, but neither is it easy being on the end of the health service. So I think whenever you find somebody who has some respect for you as a patient, you deserve to respect them as a health worker. I also continued to see the rheumatology people, which I thought was pretty marvellous. I don't often see the consultant, but I see the specialist rheumatology nurses. I've seen 3 different ones during the last 3 or 4 years, and they are excellent. They're wonderful. It's nice to see the consultant, Mr. Shabs Al-Mutafa, because he's very kind and understanding, but obviously the nurses have a little bit more time. They've just got so many good ideas, and they're always happy to listen to all the trivial things that I've been asking that you wouldn't maybe say to Mr. Shabs Al-Mutafa because he's got a lot of people to see. The latest lady I've seen, Miss Jo Kanda, suggested that I might find some help from the occupational therapy department at Bronclist. So we decided to give that a whirl, and that's how I came to meet Alison Brown. We decided, given the nature of the help that I needed, that we would see each other face to face during COVID, and I have seen her again since. Every 6 months, she either phones me or I can send her an email, and I tell her how I'm doing and what I'm finding difficulty with, particularly because some days my hands are better than others. The great thing about her is when we try something and it doesn't work, she doesn't give up. She says, well, we'll try something else then. Or even if it doesn't work, we learn from why it doesn't work, and sometimes that's helpful in itself. It's nice to know she's there because since I've known her, I've discovered frozen chopped onions, frozen chopped garlic, ginger and celeriac, all of which I now use a lot. And if we hadn't discussed it, I would never have thought to use them. It's made such a difference. It's these really small things that have helped. Chopping vegetables was really painful and my hands would go into a spasm. I don't like to ask my husband as he has other things to do. So it's the little things that have made a difference in talking to someone like Alison, because you would not want to tell your friends about these things. During COVID, it was difficult to see people and get any help from maybe our GPs, so that brought into even starker contrast the good services that I had from all the teams across the health board. So I just wanted to thank you all very much. So this was just a really lovely story we wanted to bring, because I think particularly what it's showing is that it's the small things that make a difference, and it's empowering people to live as independently as possible that really makes a difference to their lives. So I'm happy to answer any questions or take any comments.
Is there a question or comment from anybody? I agree, it's a very nice story and people love to be independent. No? Well, thank you very much for presenting that, and please thank her very, very much, because you know it's good to hear good things, as it were.
Absolutely.
So
I'll give my thanks to
Sheila on
Sheila.
my behalf. Thank you, and on behalf of the board.
Of course.
Thank you. Right, the next thing was the action log. James, would you like to come in?
Yes, thank you, Chair. The update, the latest position is in the box with regard to the single action that we continue to carry forward and make progress with. I can update further with regard to risk management in the item 3.4 later on in the agenda.
Yes, thank you. And now we have some updates. So, a report from me, first of all, in which I am, sorry, I'm not crying. I've got a little bit of a tickly cough, but I might be crying by the end of this meeting. Yes, just to say that the report from me is self-evident. Some interesting things have happened. Sadly, because of the death of the Queen, of course, Carol and I did attend a service at Llandaff Cathedral the Friday before her funeral, at which His Majesty the King was present and the Queen Consort. It was an interesting day. As regards board membership, first of all, I would like to say that it is now official, and an announcement has been made this morning that Carl Cooper, whom many of you will know already as the Chief Executive of PAVO, will be the new chair. And he will be taking up post in the middle of October, because the Queen's death did mean that we had to postpone the start of his tenure with the Health Board. So I wish him very well in his new post, and I'm sure you will all welcome him. I'll be delighted to watch you all and see how you get on once he's the new chair. But I certainly won't interfere or even appear on the premises. But of course, I'll be keeping in touch. So that's the latest news on that. And you'll see there that as regards board membership, I've already spoken to Simon, and I understand he's on the call today. Simon Wright, who's newly appointed as the representative of universities. He's at Cardiff University, and he's been the academic registrar there since 2015. So delighted that he can join our board. He's very enthusiastic, I would say. And then you'll see Two other appointments, Jennifer Owen Adams, newly appointed independent member for the third sector. And we have had interviews, we've held interviews for the local authority independent member. The recommendation that we have made to the minister is currently with her, but we can't announce the appointment yet. So things are in train, and it looks as though you'll have a full board, which would be very nice very soon. So if there are any questions, I'm happy to take them. If not, I'll ask Kirsty to give her report.
Diolch yn fawr, Cadeirydd. Good morning, everybody. The report is as read. I would just like to say a huge thank you to Claire Madison for providing me with the opportunity to get out and about to meet therapy staff in Brecon and Ystrad hospitals. I hope that myself and other independent members can do more of these visits, COVID and flu willing. It was a really valuable experience to be able to hear directly firsthand from frontline staff and to be able to listen to them and also to thank them from their work. But the report is as read, and I'm happy to take any questions. Diolch.
Thank you, Kirsty, and it's delightful that we can start getting out and about now. Meeting patients and staff. Excellent. Well, that brings me to the Chief Executive's report, Carol Shillerbeer's report. Over to you, Carol.
Diolch, Chair. Thank you very much. Good morning, everyone. Bore da. My report has been circulated. My apologies for slight delay in circulating that. I want to draw out a couple of really key areas, if I may. But first of all, I do want to just say a few words publicly in relation to Professor Vivian Hartwood, Viv, our chair for the last 8 years. And this marks, quite a juncture in our journey as a board, and as I've just tried to outline in summary, really, a chance for me in particular, but on behalf of the executive, to take the opportunity to record my thanks to Viv for her leadership, her challenge, and importantly support over the last 8 years. It was a very different health board back in 2014 when Viv took up her role as the chair. There's lots of uncertainty. There'd been some real difficulty with finance and a real challenge about strategic direction for health services in the county. And then whiz forward some 8 years, and they do seem to have whizzed by, Viv. And despite a global pandemic in amongst all of that, the health board has gone from strength to strength. So I know we'll get an opportunity later, but I wanted to publicly thank Viv for her leadership and her support across the whole organisation and NHS Wales, but also to me personally.
Thank you, Carol. I'm very overwhelmed by that, and delighted that we will still, be able to keep in touch just as friends. But yeah, it has been a very quick 8 years, and so much has happened, and so many things. Just sitting here looking out of my window, the Bromley site has come to life. We have vaccinations going there. We have a wonderful health and care academy, which the minister will be coming to open 2 days before I actually leave the health board. So thank you, Carol, for those few words.
Yeah. If I just pick up a couple of other things, thank you, Chair. And they are, pretty serious in nature, and we will be covering them later in our board agenda today. So the urgent and emergency whole system performance issue. I have repeatedly shared the pressures that the system has been experiencing, really in a more sustained way over the last 12-13 months. We haven't returned to a position that we may have experienced sort of pre-pandemic, where winter pressures were in winter, and actually it is all year round now. The significant pressures are being publicised and trailed today in the media. So hopefully, you know, the general public will get to understand a little bit more about those. And in particular, it is drawing through the challenges in social care and community services in particular. We are feeling that acutely here in Powys and across Wales. So a bit later on, we will be considering the winter plan and also the risk register, and that this is the highest risk that we are currently trying to manage as an organisation and as a health and care system. So there will be more to say on that a little bit later. On planned care, we continue to make excellent progress as a provider. There are a couple of areas where we need to progress further to meet the standard, but on the whole, the way in which we have been able to tackle the backlog of planned care has been excellent, and thanks to colleagues for that. But I am raising here for board awareness, and we'll come on to the detail later, significant concern regarding the pace at which planned care and the catch-up of appointments missed as a result of the pandemic is taking place, particularly in Wales. And there is work to bring forward some proposals for board consideration in the coming weeks and months. And then on financial performance, again, it is on the agenda. We are dealing with the critical issues today. On this agenda, we are reporting a overspend position at £2.8 million at month 5. This is a highly unusual position for this health board, and Viv, I'm so sorry that it is your last meeting, but you know, that I am reporting this level of deficit publicly. We have had an excellent track record through the years of managing the budgets, and these extraordinary pressures that we are all facing are being demonstrated through the financial position. So at this stage, there is a forecast deficit of £7.5 million at the year end. And now very clearly, that is not a position we wish to be in. We will touch on the detail more so later on, but I've just outlined there the steps that I've taken as a chief executive and in terms of my accountable officer responsibilities. A couple of other things to draw to the attention, and that's on strategic service engagement and consultation. There are 2 or 3 key elements actually to draw out. We know that there is significant concern in parts of our community around the eMERTS service, so that's the Emergency Medical Retrieval and Transfer Service, the air ambulance services, and the potential, and I stress potential, at this stage for a change in base. Now, there's a lot of work going on behind the scenes to understand the detail behind some of the work that has happened in that eMERTS service. As a health board, we are members of the Emergency Ambulance Services Committee that commission eMERTS, so that is our particular interest and role in this. Welsh Health Specialised Services Committee, I wanted to draw out in my report, cochlear implant and bone anchored hearing aids, hearing appliances. WISC will be entering a period of engagement with people around the development and configuration of this service. We will publish further details on our website on behalf of WISC, the Joint Committee, and we will, through our communication and engagement team, enable all stakeholders to have access to that and provide additional information as required. And then there's a piece in relation to Hereford and Worcestershire stroke services in terms of the configuration of hyperacute stroke services as an engagement process, and we're very active in relation to that. I'll take the rest of the report as read, but Chair, I just wanted to draw out those particularly key matters in my report this month.
Thank you, Carol. Very important, and I know people will be watching. The independent members, I'm sure, will be keeping an eye on all those things after I've gone. So thank you very much. Right, that brings us to the second section of the agenda. And so we start with the annual report on civil contingencies. So our Director of Public Health, Mares, thank you.
Okay, thank you, Chair. Borada, good morning. So the purpose of this report is to present to the board the civil contingency annual report detailing the key resilient activities undertaken during the last financial year between April 2021 and March 2022. So members will be aware that the Health Board is a Category 1 responder under the Civil Contingency Act and is required to comply with 5 statutory duties. So during the past year, the Health Board's ongoing response and recovery actions have mainly been to the COVID-19 pandemic, and this has continued to remain the focus of the Health Board's resilience activities. And in line with this, the Health Board has continued to work in partnership with members of David Power's multi-agency Resilient Forum to respond to the COVID-19 pandemic. So the report demonstrates that whilst civil contingency planning and delivery has progressed, I need to draw members' attention to the annual review of the Major Incident Emergency Response Plan has been updated, but there are some programmes of work that have been impacted due to the focus in responding to the pandemic, and in particular, limited opportunity to participate in training exercises at a local national level. So I'll take the report as read, but during the next financial year, I wanted to draw members' attention to the focus of activities will be to review and update the key plans and policies, develop a new organisational policy for emergency preparedness and resilience, outlining the key roles and responsibilities across the organisation, and to update the training plan for the organisation and participate in national and regional exercise as they are organised and planned. So happy to take questions and would ask members if they're happy with the report, whether we could then proceed to publish the report and agree to key activities during this financial year. Thank you.
Thank you, Matt. Does anyone have a question or comment about this report? Ian, would you like to come in?
Yes, thank you, Chair, and thanks, Mez, for this report. I just wanted to make a comment, really, with regard to the business continuity and just to emphasise the importance of getting these plans in place. And this is a board responsibility, but it's also an operational responsibility. And just to emphasise the fact, particularly some discussions we're having recently on the ICT side, we're reliant very heavily on technology, and experience elsewhere would highlight the fact that when there are problems, I know we've got a lot of things going on globally at the moment, and cyber attacks are not uncommon, even in the public sector, sadly. But the real importance that departments get their heads around how they could continue to function in the absence, I think this is really important. So I just wanted to emphasize that part of the report at an operational level, rather than for folk to see this just as a kind of strategy document. There's a real practical purpose in this that I know that you're trying to highlight. So thank you for that, Mez. Yeah,
thank you, Ian. That's a really good point. Are there any other comments? Any questions? Well, if not, I think we need to ask you whether you're happy to approve this Civil Contingencies Annual Report for publication. Everyone in agreement? Thank you. And also to proceed with the recommendations that are in the report. So thank you, Les. Thank you very much.
Thank you. Diolch.
Right, the next matter for consideration with regard to approval is the Integrated Performance Framework. So I think Carol and Steve Powell are going to present this.
Yes, thanks very much, Chair. This is, I'll pass across to Steve to take us through the documents now. This has been one of the most important frameworks that we've had as a board over the last sort of 8 years, and we have taken the opportunity to review and revise this framework, and in particular to take into account our commissioning assurance framework that we had sitting alongside this. So take an opportunity to draw those two things together. If I can thank executive team colleagues and actually all colleagues across the board, because we worked on this in our board development session back in the summer, and provides a really important opportunity for us to take an integrated and ensure we continue to take an integrated approach to performance. It also within that underlines the importance of quality performance as well. So that is particularly important in terms of the duty of the new duties under the Engagement and Quality Act that is being implemented currently. So I'm not going to say any more, Chair, just to hand over to Steve to present the paper.
Thank you, Carol. Thank you, Chair, and good morning, everyone. And for those colleagues looking at the pack, we're currently on page 47 of the overall board agenda pack. And there's a 4-page covering paper which Carol has started to describe, and then the actual integrated performance framework starts on page 50 of the pack. The papers, as Carol said, the paper has been drawn together to amalgamate both the previous improvement performance framework and the current commissioning assurance framework. Because what we're seeking to achieve is a more holistic approach to data insight and reporting across a variety of domains, including finance, activity, performance, quality, safety and workforce, so that we fully understand how our services are performing, our resources are being deployed, and some of the risks that we may need to mitigate against as part of our overall service delivery. And as Carol said, we've had several sessions in the build-up to this paper. Back in June, a board workshop, informal executive committee in August, and a further discussion last week in terms of bringing this paper together. And so really, this paper is asking that we discuss the content of the revised framework and to approve the suggested revisions if acceptable. So the report itself has 10 sections in terms of the overall framework, and I'll just take colleagues through some of the key components of the framework. So section 1 really starts to get into the detail of what we're trying to achieve, that we're looking to integrate all indicators, and there's a particular section in bold around the holistic approach that we're seeking to achieve as part of this revised performance framework. The scope has been expanded, and what we're seeking to achieve in this area is that we have a consistent lens of review and performance oversight into all services the Health Board provides and all services the Health Board commissions. Now that's a slight change from the current frameworks in existence, but we're aiming for that consistency of view across all services. The performance framework itself is not supposed to replace or duplicate any inspectorate role, so that may be performed by HAW or the Care Quality Commission in England. It's our own performance framework where we're trying to assess the performance of our services, either commissioned or provided. Section 3 has got an expanded component of the framework, and what we're seeking to focus on in this particular framework is an expanded role across the view in the quality domain, improving our focus on outcomes, And we put in as a note that as we want this framework to be in situ for at least 3 years, but with an annual revision, by definition, because of the changing nature of the NHS, it will evolve over time. But the fundamentals of good oversight hopefully are captured in this document. Section 4 describes the roles and responsibilities of each component or layer of the organisation, and this section also covers the key areas that we're seeking the improved integrated performance framework to cover. So on the bottom of page 59, it shows in tabular form the core areas that we're seeking for the framework to cover, right? Access, quality, finance, patient experience and effectiveness, finance and value, governance and risk, with some supporting measures as to how the framework will operate. Section 6 deals with how we will operationalise and use the framework, including the use of benchmarking where appropriate, so we get that wider aspect of performance oversight, and also a section on escalation and de-escalation of any issues that might arise throughout the organisation. There's a section around section 9 deals with the implementation, and we're looking for a phased approach during the remaining part of 22-23 with full operational impact and delivery from the 1st of April next year. And we're suggesting that the implementation plan and any changes to the framework be managed through the Delivery and Performance Committee. Section 10 then deals with some of the supporting information and frameworks that are effectively the building blocks of the overall framework, so including board assurance framework, NHS Wales escalation framework, and so on. So I will pause there, Chair, and take any questions.
Yes, before I ask anyone else to come in, I'd like to congratulate the exec team on producing this, because I think it's an excellent idea to have an integrated performance framework at drawing everything together. And I was very pleased to see the clear lines of accountability, really good governance practice. Roles and responsibilities, I draw the board's attention to especially section 4.1 in particular, just so that everybody knows what they're accountable for. Excellent, thank you. And of course, benchmarking is something that the Minister later on, which comes up later on in the document, is very keen on at the moment. Now, are there any questions or comments? We do have an opportunity to discuss this. Mark, would you like to come in? Go on, Katie. Sorry, Katie. You were before Mark. Would you like to come in first, Katie?
Yeah, that's fine. Mark, I'm happy to take the question.
Okay. Mark?
Thank you, Chair. I just wanted to say that I welcome the report and the quality of the presentation. It can be sometimes a dry subject. We go through lots and lots of data in committee, and I just wanted to make my reflection clear about how I see the improvement of that data and the breadth of that data and the presentation improving as we go along. So I think action on the ground is actually being reflected and hopefully supported by this more strategic document. So again, thanks to Steve and the team for the work that they've done around that.
Yeah.
Thank you, Mark. I echo that. Katie, I think.
Yes, thank you, Chair. I just wanted to, I suppose, make an offer really around the patient experience and effectiveness core area, and we'd be quite keen to support in providing some of that evidence. And I think we've talked before about how we are now collecting patient experiences and not just complaints. So be very, very keen to feed that in if that was helpful.
Yes, thank you, Katie. Thank you very much. I think, Carol, did you want to come in next, or would you rather come in at the end of this session?
Yeah, at the end, if that's okay, Chair,
Right.
thanks.
So that brings us to Claire Roche then. I think you're on mute, Claire.
Sincere apologies. Good morning, everybody. Just wanted to really build on the point that colleagues have made around the preparation for the Quality and Engagement Act, and of course currently at the moment the duty of candor consultation is actually open, and the duty of quality consultation is due to be opened in forthcoming future, the near future, and I really welcome this integrated approach, and the timeliness for our preparation for the Quality and Engagement Act is extremely important, and of course for that to be demonstrated across the organisation in all of our business. So this couldn't be more timely, and I welcome it. Thank you.
Thank you, Claire. And Kirsty, you have a question.
Thank you, Chair. Can I just say again, to reiterate the comments about how welcome this integrated approach is, but if I could pick up where Katie at the CHC ended, and also paragraph 7 around feedback, to understand how we will gather intelligence from a number of sources, including patient feedback, and how we will make that feedback section a reality. So it's the not what are we going to do, but the how are we going to do that question with regards to the involvement of patient voice and feedback from a number of different sources.
Yes. Do you want to take that, Stephen?
Yes, I can do. And I think, Kirsty, it's going to be a variety of different modes of communication and mediums. So, you know, from leaflets and surveys that are issued to patients after their treatment, but also more proactive campaigns that could be placed in a variety of access points, whether that be in pharmacies, primary care, MIUs, and so on. But really, as we're a commissioner of services, getting that feedback from the trusts that deliver services and on our behalf, it will be vital, so that we gain that full appreciation of both service delivery, quality, and feedback, and whether those services are really delivering what they're set out to achieve.
Thank you, Steve. Is that clear, Kirsty? You happy with that response?
I think Claire Madsen has commented that she'd like to come in, because obviously some of this falls into Claire's portfolio.
Right.
Thanks, Kirsty, for the question. I think the other things to mention is that we have commissioned a new software package called Civica, which we are in the process of implementing at the moment, and that will allow us to collect real-time feedback from patients and service users and the public, and that's both in our commissioned services and our delivered services. So we will have a much wider reach, and it will also allow people to deliver their feedback in different ways, and we can make accessible questionnaires and things like that. So we will have a much wider reach once we've implemented that. And within services, we are doing some work around patient-reported experience measures and outcome measures, which will become routine in some services now, where we will be able to see the outcomes of the services that we're offering, as well as the experience that patients have.
Thank you, Claire. That does clarify. Is that all right with you, Kirsty? Thank you. Now, Ian wants to comment.
Thank you. I just wanted to build on that and just suggest that we also need to think about how we gather more informal intelligence and how we process that, because it's quite a difficult area, but I think there are opportunities for us to consider that more strategically. So I welcome further discussion and an opportunity to discuss the opportunities, how we do that in the future. Thank you.
Carol, would you like to come in now? Oh, hang on, Simon's. Wait a minute. Sorry, Simon. Simon Wright has a question. You're on mute, Simon. I think you have a sticky button, mute button. No? We still can't hear you, so. Oh, I think this problem, are you coming in from the university here on this?
Yeah, Chair, I think there might be a technical problem
Yes,
with Simon's
yes.
connection.
I think that we've had this problem before. I'm very sorry.
Shall we just see if we can, I can't unmute him from the system here. Do you want to try again, Simon, to see if you can unmute?
Is that better?
Yes. Yes.
Oh, thank you.
Thank you.
So it might be a very new boy question, in which case I do apologise. But with all kind of performance measuring, the question is around the balance between lagging indicators and leading indicators, and how far, I know we have that challenge in the university sector, how far have we got the balance between those things that are kind of forecasting or performance trajectory type indicators and help us forecast things, versus the look back of, well, how have we done against the targets we had? So I'm just interested generally is, how far does the board feel we've got the balance of those things right, and how far might we be developing more leading indicators that help inform future direction of the challenges we face?
Good question. Thank you.
Yep. Yeah, thank you, Simon, and welcome. Yeah, good question. And really, it depends on the subject matter, to be honest. I certainly want us to get into a more leading set of indicators. So, for example, you know, if we've got an increase in referrals and we've got limited capacity, what are we going to try and do to mitigate that obvious surge in demand, in other words, and work out options to deliver that increase in care. The lagging is always good, so that you can see where your performance is at, and particularly from a reporting perspective, you know, we have to submit annual plans. There are a lot of milestones, indicators that we need to achieve and deliver against across a broad range of domains. So we always need to know where our performance is at. But I agree. I think a good plan and a good planning function of any organisation is a good understanding of those leading indicators, so that you're aiming for your service to be optimum to deliver, in this instance, healthcare. Thank you.
Satisfied with that, Simon?
Yes, thank you.
Thank you. Thank you for that question. Now I think we can ask Carol to come in.
Yeah, lovely, thanks. And I thought they were really helpful questions, and just to endorse those comments, particularly around patient and citizen feedback. So that is really, really important, and I know that the Patient Experience and Quality Committee will be looking at this matter at its next meeting. It's also important for us to get staff experience coming through as well. We know the evidence that relates to improved care is a direct correlation with how motivated and the engagement score of staff and staff well-being, and a really helpful question, I think, on the not just looking in the rear view mirror as what's happened, but really planning what's going forward. And I think Steve's leading a important piece of work on how we get that demand and capacity knowledge and understanding through our data systems more effectively. The comment that I really wanted to make, Chair, was in implementation. So there's quite a bit of work to do in implementing this now. So we will be, through Steve's leadership, developing an implementation approach, and that's already started. And that will then report through my own finance and performance executive group, but through to the delivery and performance committee of the board. So the board should be able to track through how we're getting on in implementing this in practice. So hopefully that's helpful.
Thank you. Does anyone want to ask Carol a question? That did clarify it. I can see what you mean, Carol. Work for the future. Well, in that case, could I ask you to approve the suggested revisions in the light of the discussion? Everyone happy? Yes? If you just indicate, I'll assume that silence is assent. Thank you. And happy to also to recommend adoption and implementation within the Health Board. Yes? Excellent. Thank you, everybody. Thank you. So those were the only two items for approval or ratification. Now for discussion, we can turn to the integrated performance report. Again, I think this is you, Stephen, for month 4.
That's correct. Thank you, Chair. So colleagues, in terms of navigation around the board pack, this report starts at page 77 of the board pack issued. There's a 3-page covering document, and then there's rather a large 95-page performance report. Now, I know we've just discussed the framework. This is some of the output of the current frameworks, and we will move to a more exception-based reporting for future committees. But so at the moment, the level and style of reporting is consistent with what's has been produced to date. So this is the performance to month 4. It went to the Delivery and Performance Committee recently, and so this is to discuss and note the performance of the Health Board. The report itself, so on page 80 onwards of the performance pack, there have been some changes this month which have lengthened the document. So there are 4 new slides at the beginning of the pack, and I'm referring now to the numbers in the bottom left-hand corner of each slide going forward. So slides 4 to 8 of the integrated performance report describe the various changes to some of the national indicators that have been required by Welsh Government to be implemented as part of the overall NHS Wales performance framework for the 22-23 financial year. So they describe the both the measure and the rationale for inclusion. As a result of the new indicators, we then incorporated new slides to record the performance of the new requirement. We've only done that where we actually provide the service. If we don't provide the service, we need to import that data into our overall oversight as part of future reporting requirements. Carol mentioned in her Chief Executive report the position on planned care. So we've significantly expanded the reporting of the performance of planned care, not only on our provider services, but with every health trust that we commission with across England and Wales. So slides 82 to 94 of the report show the performance of the waiting list position for each of the trusts, and particularly the long waiting patients within those organisations. The final slide includes some new screening information that was absent from previous reports, and we will seek to include that in all reports going forward now that we have that regular flow of the data. And I've mentioned this, but I want to mention again, we will look to move to exception reporting in line with our revised performance framework to make sure that the pack is a little bit more succinct going forward. I wanted to talk about some performance exceptions. Page 2 of the pack describes the Health Board's performance against the 4 quadrant indicators. And as Carol mentioned again in the Chief Executive report, the ongoing emergency pressures are having a lot of consequences, not only for the delivery of the urgent care performance standards, but also their impact on planned care performance standards, particularly if patients have to be cancelled or other capacity concerns that affect the delivery of planned care. Looking at the dashboards that then start on page 10, I'll draw out some performance exceptions and seek to draw in some of my executive colleagues, either as part of the discussion or afterwards. So on page 10, the quit smoking indicator is not performing to the standard. There are actions being taken across primary care, including pharmacies and extra training for smoking cessation advisors to try and improve that performance target. Similarly, on page 10, indicator 14B and 14C around flu vaccinations, we're also seeking to improve that performance, particularly now as the autumn winter period is upon us. Page 11 of the dashboard, the out of hours has continued to experience significant challenges. That's indicator 16, and similarly, as Carol mentioned, indicator 31, the response times of WAST ambulance performance against the 8 minute response time is proving very challenging, not only across Wales, but specifically those conveyances into Powys to onward convey patients to A&E departments. In our own provider arm, generally our performance is excellent in terms of planned care recovery and consistency of delivery. We have got some therapy breaches, that's in indicator 41, which has risen to 180 patients breaching the 14-week target, but there was some short-term sickness that caused the increase in the number of patients being over that target, which we're seeking to rectify as soon as possible. Page 12 of the dashboard gets into more detail around the number of patients waiting out of county, and since this report was produced, the figures have improved a little bit, but so the latest performance is that 22 patients in our English providers are waiting more than 104 weeks for RTT treatment, and that's 22 patients in Robert Jones and Agnes Hunt waiting for spinal procedures. But across Wales, so the position is, whilst it's improved from there's still 682 patients waiting across Welsh health boards for mainly for elective care and mainly for the biggest cohort being orthopaedics. So as Carol said, we are looking to see what actions we can take as a health board to try and reduce some of those waits for our patients elsewhere, notwithstanding that we haven't got a district general hospital, but we do have day case facilities in Brecon and in Drindod Wells that could put some of these patients through those services if resources allow and we're sort of clinically safe and appropriate to do so. So it's an area of concern, but also some opportunities to try and improve access for patients. Also on that page, indicators 57 and 58 around mental health. Those current service targets are not being met, but it's as a result of staff sickness, some vacancies, and increase in demand. So I'll ask Hayley afterwards, Chair, to probably come in on and just comment a little more about those two particular indicators. On page 13 of the pack, our agency spend and sickness absence is reported, and both indicators are showing a slight increase from the previous reporting period. And finally, that was it actually. Those are the exceptions that I wanted to draw out. Sorry, Jeff.
Thank you. Well, there's a huge amount of information in here, a lot of detail, isn't there? I mean, it took me quite a long time to plough through it and make some notes, but I'm sure the independent members will have some questions. I can see Robert first. I believe it's Robert first.
Yes, thank you, Chair. First of all, it's very pleasing to see that for the work that we do in-house, cancer screening, mental health interventions, CAMS, other assessments, you know, that we are the best in Wales, and maybe there's a hint there of what the difference we can make as we repatriate services, you know, in the future. I have a specific question though on the in-hours GP access data, which is page 108 on the pack there. And according to the bar chart there, we have now achieved 100% percentage of GP practices which have achieved all the standards. And then on the right hand side in the sort of orange, there's a narrative there which talks about difficulty in making GP appointments and the clarity around the expectations, etc. Could you confirm that the achieving the standards, what the standards here do not measure is how easy it is for a person to get an appointment, that they measure things like availability of email services and how many minutes it takes to answer the telephone and so on? And is there any thought about how we can measure the backlog, if you like, the difficulty that people have trying to get appointments? Because it does seem to be the comment, you know, as you walk along the street, I get more comments about that than about anything else. Thank you.
Thank you. Do you want to take that, Stephen, or?
Yes, I'll start. I'll probably ask Hayley to contribute as well, Chair. So thank you, Robert, for the questions. So they are slightly different. I agree that so the access standard is a measurement of the national indicators set out, but that is different to response times and actual access standards that patients may, you know, truly experience firsthand, so to speak. And I'm not sure how we can measure that, to be honest. And I'm apologies, that's probably all I can say on that indicator at present. There is a lot of evidence from, as you say, the public, family, friends, and so on and so forth, that GP access can be difficult, but measurement, I think, of that is quite tricky at present.
Carol, do you want to? Can you add to that?
Yeah, thanks. And Dr. Richard Stratton may be able to contribute here as well as a GP. He's deputising for Dr. Kate Wright today, who's on leave. But Robert, I think you're flagging really well the core issue about what is the government measure that is being responded to. So that is largely around, you know, are the practices open from one hour, certain hours of the day, extended to 6 p.m. in the evening, versus really what we hear reasonably consistently about, well, I couldn't get to see my GP. And so that experience element of whether the service is truly being responsive. And of course, in the English NHS, there's quite a lot of discussion about that at the moment in terms of, you know, 2 weeks maximum to see a GP. You know, I think there's a lot underneath this that we need to understand. Primary care is changing enormously. It's becoming much more multi-professional. So some of the perhaps measures about, you know, GP access, perhaps we'll need some, you know, review and revision as this becomes much more multidisciplinary, and that the means by which consultations and advice takes place changes as well. But I think we've got a real tension in there. I just wonder, Chair, if Richard comments, and then I think Hayley is offered to comment as well.
Yes, I can see Richard's. Richard was going to comment or ask a question anyway. So if you'd like to do both now, Richard, that would really help.
Thank you very much. Thanks for the opportunity, and nice to meet everyone for the first time today. Yes, as a working GP, this is something that exercises my mind every single day. I wonder if part of the problem is that we talk about access rather than availability of service, because it feels to me that access is actually really good. Our phone lines are open, our receptionists are available, but we haven't got the resources in all cases to meet the demand that there is from our public. and we're working in a finite capacity dynamic, really. So the measures, I think your point, Robert, is absolutely right. Measuring access gives us 100% compliance, but availability and our responsiveness to patient need or demand or want is a very different thing, and we need to be more refined in how we measure those things. It's a complex area because some of what patients are reporting is not that they couldn't get to see a GP or an allied professional in our services, but it's that they couldn't get to see them at the time that they wanted to. And convenience is very difficult to satisfy in a health service of this nature. So it is complex. When we survey patients who have received care in services, satisfaction is usually very, very high. When we survey patients about concepts like availability, can you get to see your GP, do you? The answers are often less. Sometimes those people haven't had the experience of accessing the service. It's a perceived problem, and we really need to get to the heart of that. And I wonder if working with some of our patient participation groups and the like is the route forward here to get real lived experiences and some qualitative data to back up our feelings.
Thank you very much for that.
Sorry, Chair, my question was something completely different, but do you want me to come back to that later?
Yes, come back later in that case, because I think Hayley needs to come in as well on this one point. Hayley.
Yeah, thank you. I'm not sure if I can add very much to Richard's really comprehensive response, but I think a couple of things I'd want to mention. Obviously, what we measure, we will have more detailed access reports coming through at the committee level outside of the integrated performance report, which is the overarching measure that we have nationally that we report against. So some further assurances that more detail will come through around some of the broader questions that Robert raised. But I think Richard's point around the patient participation groups, and in particular the Community Health Council, have been really important, giving us insight around some of the survey work that they've undertaken. So we do have an issue with the public, not just in Powys but nationally, around the experience and feelings about access and accessibility of primary care that we do need to address. So some reassurance really that not only through our usual contract arrangements, but we're in the process of doing practice review visits currently, and also in the work of the accelerated cluster development and the existing GP collaboratives that we have. We are very aware of this issue around the public experience and view of primary care and how we need to work on that proactively. I know that there's some national messaging and work being undertaken through the National Programme for Primary Care, but also locally it's a really serious matter, and we do spend quite a lot of time speaking to the CHC, but also to the practices themselves about how that liaison and communication and perspective with their local population is needing to be built upon. And some of the mechanisms that we normally would have relied upon during the pandemic didn't continue. So we are having active conversations around how we can get some of that participation increased now as we move forward. Thank you, Chair.
Thank you, Hayley. Well, we'll continue with the other questions then. Thank you. That does clarify matters. It's obviously extremely complex. I think Kirsty had a question.
Thank you, Chair. Could I move on from primary care to mental health and our ability to meet targets in mental health? And I'm particularly interested in exploring the nature of the increasing demand, which Stephen referred to, and whether we have a sense of whether that demand is just a temporary rise as people begin to engage more, or whether we anticipate that this is going to be a longer term trend, and our understanding of that demand in mental health services. Secondly, can I ask about ambulance services and what steps the executive team on discussions they're having with ambulance services to look at improving performance within Powys? And then finally, what steps, Stephen outlined some of the things that we may be able to do with regards to treatment times by repatriating some services into our own hands, but we know that what we're looking at here is an exacerbation of health inequalities that already exist in our population. And I'm wondering, Stephen, if you could outline what discussions we're having as a commissioner with our commission services partners, particularly in Wales, and what they're telling us about their barriers to be able to make progress in treating Powys patients. Thank you.
Thank you, Kirsty. Some searching questions there. I don't know who wants to take these. Is that Stephen or Hayley?
I was going to say, Chair Hayley, do you want to pick up the mental health ones, please?
Yes, of course.
Thank you.
Yeah, thank you, Kirsty. And I think that the position around our increasing referrals currently, speaking to frontline clinicians around this, I don't think this is a short-term blip. I think this is something that we're expecting to continue during this period. And we have had a substantial increase in referrals, but also the nature of the support that the clients require and the complexity of some of the presentation that we've had feedback again that has changed in the last few months, and in particular in terms of the interventions that people require. Some of them are more longer term and more specialist in nature. So some of those examples that I've been talking through with the teams is around the increased need for cognitive behavioural therapy, but also some of the psychotherapy approaches that we've got, eye movement, desensitisation and reprocessing. These things are increasing, leading to deliver for our clients. So I think that we have got an issue that increasing demand feels as if a clinician described it as if it's now that the pandemic is hitting the mental health services. And despite the fact that we have been undertaking several actions, really, not just in terms of how we are organising our teams, some of the systems and processes and how we function as a department, we've also invested further in Tier 0 and Tier 1 services, and we've got additional funding that we've identified now going into this next period to try and increase capacity. There is a mismatch in terms of increasing referral rates and the capacity we've currently got within the system, but we are expecting some improvement against the targets over the next few months, despite the increasing demands, and that's partly down to the way which we've changed the team's functioning. Also the additional investment, but we've also had some quite substantial staffing absence in some of the teams, and really pleased really that since this month, based on phased returns, we've had some key members of staff return back to work, so that's been really important as well. So yeah, it's one to watch. I would say that we will need to continuously review this, and perhaps we could have a more detailed discussion in committee, particularly around the nature of that referral demand and the complexity of the interventions going forward. And we're seeing it across all ages, is what I wanted to just pick out as well. The other area that we're working on is around data quality and capture. There are some systems issues at the moment which we're working through really carefully to try and address, so that is no longer an issue for the frontline teams. But yes, quite concerned about the increasing demand on the services and also our ability to respond over the next few months. Some improvements expected, but still a mismatch, I would say, between the available capacity and the rising demands.
Thank you, Hayley. Are you happy with that response, Kirsty? Thank you very much. Again, it's a difficult area for everyone, isn't it, at the moment across Wales and England. Stephen, do you want to deal with Hayley's second question about ambulances? Or Carol, did you want to come in?
Yeah, I'm happy to pick up the ambulance issue, Chair, because later on in the papers is the latest update from the Emergency Ambulances Services Committee. So I can almost take that now, and we will touch on this in the winter plan item as well. So it's really, really important. I'm just going to pull out a couple of things that I think are of particular note. So the Emergency Ambulances Service Committee, which is a committee made up of the 7 health boards, of which I am our health board's member, all members of our chief executives, met recently, and we discussed the extremely serious situation that we are experiencing in the health and care system that is resulting in delays in ambulances, and the report outlines some of that. So we were very concerned, particularly as we go into the winter months. So what are the key areas that we're focusing on? So one of the big issues that ties up ambulance services is handover delay at ED departments, and we really should be working, and I know that the system across the board is working on ensuring that wherever possible people can be supported with their situation in alternative pathways, rather than feeling an ambulance and admission to an acute hospital is required. That is some of the work that we are doing in our frailty and community renewal programme. But there's a big thrust around prevention of admission, and particularly around the hear and treat service. So people ring up for an ambulance, they have an interaction with a professional, and trying to increase the numbers of people who then don't have to then have an ambulance response and can be supported in a different way. On handovers themselves, a commitment has been made by all chief executives of health boards in Wales to reduce handover delays significantly, and to increase the number of what we call immediate releases, which means that if there is a red call, a life-threatening call, the ambulances are released from the forecourt outside the emergency departments. The big issue that would support ambulances more is the discharge from hospital, and I'm personally involved with some work across Wales to increase the capacity of community care services that will directly have a positive impact on the ambulance service. The final thing that I wanted to say in relation to what the conversations are and the work that is going on relates to, in particular, investigations and reviews where the cases are where there's a poor outcome or there's a serious incident, and there's joint work on investigating those and looking into each and every one of those incidents. And then finally, there is a focused area on maternity, and we have raised concerns around the rurality of Powys and the need to ensure that the ambulance control really does understand the pattern of maternity services here in our rural area. So thanks to Claire Roach, who I know is taking this issue forward with the ambulance service and other colleagues across Wales. The Chief Nursing Officer is also involved in that. So plenty to say on ambulances. We could probably fill the whole meeting, Chair, but if I just leave that there, I know we'll be following it up. Right.
Yes, thank you. I don't know, were you happy with that response? Yeah, thank you. I know Richard wanted to come in with a different topic. Is this right, Richard?
It is. I hope there's time for it, and so it's a reflection on the integrated report and the integrated plan that we've seen this morning, and I wonder really where do we go next with this in terms of commissioning. What I see at the moment is we reward activity. If we look at flu, for example, the providers of the flu vaccination get rewarded for the number that they perform. but we're not incentivized to a collective target such that Powys hits its targets or even excels within those targets. And so we can see on the chart that there's a deterioration in the administration of influenza vaccine to pregnant women last year. But that ought to be a system response to that. Lots of us can do something about it, but I don't think the incentives are quite there. Similarly, there was mention before of lead and lag measures, and a great example is referral data. We produce the work for secondary care to perform, but we're not linked to that performance as an outcome at the other end. So I'd like to, I just want to hear a little bit about how we could possibly redress the balance between activity and outcome in our contracts and our incentives.
Yeah, that's very interesting, actually, and good to have you here. Just the sort of question a GP would ask. Stephen, can you deal with that? Or
yes, I will.
Yeah,
I will. Thank you, Richard. And I do have a response to Kirsty as well, but I'll come back to Kirsty in a while, if that's okay, sorry, Chair.
Yes. Okay.
Yep. So Richard, just for continuity then, right? Incentive payments in Wales, they don't operate the same from a finance perspective like they do in the English NHS. So in the English NHS, money follows the patients. The more activity you do, typically the more you get paid. And in Wales, the mechanism is more block contract based with a certain level of tolerance. So there would need to be a revision to that mechanism if it was to go down more of the incentive route. All I can do is take that comment back and work with finance colleagues to see if there would be any merit in devising certain schemes to link outcomes with additional incentives. I know Pete's on the call. And then in terms of linking activity with referrals, outcomes, performance, that's definitely an area that I see being developed, and reporting back that performance and those statistics at practice level, because I don't think at present we do that strongly enough. So as part of the integrated performance framework, I want to replay a lot of information back to practices so that they can see not only the volume of referrals, but the likely access times, the size of waiting lists for practices, and then ultimately outcomes, experience, and effect on the wider determinants of health. I mean, that's ultimately the journey that we need to go on. But you know, it will take some time to achieve that aim, but something that we should definitely seek to achieve as part of this improved review. Thank you, Chair. Shall I come back and answer Kirsty's question? Yes. Okay, so Kirsty, you asked around how we engage with the health boards across Wales, and particularly around long waits. So as a health board, we meet with all health boards and all English providers, as it happens, on a regular basis. We've met a few Welsh health boards this week, and long waiters is always on the agenda as part of the wider access domain. But recovery in Wales is a lot slower in terms of long wait reduction than it is with some of our English providers. The health boards themselves have been they've submitted recovery trajectories for the eradication of long waits, and they themselves are being performance managed on a almost weekly basis by NHS Wales, particularly through the delivery unit. And so health boards have to send in weekly performance reports in terms of how they're seeking to achieve their reduction in long waits. So we now get copies of that in terms of parish resident extracts, so we can see now where our patients are on the waiting list and the likely clearance time to eradicate those long waits. So we've met with one of our particular health board partners this week, and we've asked now for the patient level detail for the long waits in that health board to see whether we can expedite the recovery of those treatment times. around some indicators I talked about earlier. Are there those more simple, lower complexity day case procedures or diagnostic procedures we could put through our own provider services, or do we need to see whether we need to move patients around the system a little more, including potentially into English providers if the capacity exists, and we can agree that. But it is a difficult issue, and it will take time to resolve, and that's why it's a higher escalation, both at a board level, but also as part of our day jobs to try and reduce those waiting times. But it will take a long time. As one of the reports that came to Delivery and Performance Committee earlier in the month was a report by Audit Wales, and within that paper there was quite a long forecast recovery trajectory built for the recovery of planned care waits within Wales, with at the current pace that would be a recovery of planned care wait times by 2027, but with a more challenged recovery that could take up to 2032 to be achieved. So, you know, there's a huge challenge, but at least the most beneficial things that we're now cited on the level of detail that we need to try and influence and expedite that care, whereas previously we didn't have that access to that level of information. So I'll pause there, Chair. Yes,
thank you. I think we all need to pause after that. Karen, did you want to come in? I'm not sure.
Steve has said it all really. You know, when Steve talks about 2032, that just isn't, you know, something that we can feel that we can tolerate in terms of, you know, the crushing pressures that there are on the NHS and the impacts that has. So, you know, we've really got to, I think, as a board, and I know we've started this discussion in planning for next year, be really clear about what we can offer to the people of Powys and what might be acceptable to them in terms of the ability to travel to different places for care and treatment. And it's that flexibility that I think that people and we will want to build up. You know, we have got an increasingly a proven track record of being able to provide care closer to home. So if I just think about our wet AMD services, macular degeneration up and running in Llandrindod, nurse injectors, etc. A little bit pre-pandemic, I was talking to some people from the Llandrindod area, and they wanted to express to me how pleased they were that they could have their eye surgery there. So we can do things in Powys, and we are trying, you know, working very hard, in particular in North Powys, on the North Powys Wellbeing Programme, to be able to provide more care close to home. So I think we need a level of ambition in amongst all of the constraints that we are facing, a level of ambition to bring as much care closer to home as possible. And it does start with those, looking at those opportunities, as Kirsty rightly asks about, is where are other health boards and where are our patients and what repatriation opportunities there are. So I'm looking forward to us working through this over the next few weeks and months and bringing back some of those proposals.
Thank you. Thank you, Carol. We do now have a question from Ian and then Mark, and then I think it will be time for our comfort break. So Ian, would you like to come in now?
Yeah, sure. Thanks, Chair. Just a bit of reflection really on Simon's lead-in lagging and also Richard's comment in terms of outcomes with regard to this performance report, which is really comprehensive. And sadly, the only example I've got is one on page 73, which is the Welsh Nursing Clinical Record. And having argued the case for departmental business continuity plans earlier, we see that one of the mitigations in that table for the use of that product is to continue to work on paper. So I've no difficulty with that from a business continuity, but I'm just wondering really whether we need to give some thought to the unintended consequences of our mitigation, which in that particular instance, I'm just using that as an example, is that staff need to use a digital product and they need to maintain paper records at a time of unprecedented, pressures that we've clearly just had a very difficult conversation about, and whether we need to consider looking forward to those lead-in indicators. When will, so specifically on this, a very unfair question to pick on, because this will be true of the whole report really, is when will we be in a position where staff don't have to double entry on that? And there will be other examples. So the mitigations, whilst it's a positive thing in terms of Simon's challenge to look at lead-in indicators, maybe we need to consider some balance in this report, which is what are the unintended consequences of this, and what are our more kind of strategic plans to get us to a place that is different and providing more of the sorts of things that you've just discussed, Carol, but also more of the things that we talk about in our in my view, outstanding combined health and care plan.
Very happy to pick that up, Chair. Can I just say how useful the conversation is, because and Simon, thank you, because I think your comments, Ian, are about recognising the value of looking in the rearview mirror, but actually being much more focused on, so when will we have achieved X in order to then, make some substantial changes? And the example you give, of course, is that, the digital ones. And this is where the development of better understanding of demand, capacity, how much expertise we've got in certain areas, how these things can be deployed. And as Steve said earlier, this gets into then the detail and the depths of planning, both strategic and operational actually, and how confident we can be that our plans and the way in which we plan is strong enough to take us into that leading area, rather than always looking about what happened last week, last month, last year. So that's absolutely the direction of travel. We've got to work on improving data to help us with that and understanding. We've also got to work on programme and project management, and I think we are progressing in that area. And we've got to work on the ability to change as an organisation and to be flexible and adaptable. So those are the things, Ian, I think we're going to be discussing more in this quarter now as we're doing our IMTP, our strategic planning preparation. And I know that on the particular matter for digital, as a board, we will be considering that during a meeting in October. So hopefully that's helpful, Ian and Chair.
Thank you.
Thank you. And that'll be music to Ian's ears, I'm sure. Right, Mark, finally, before our break.
Thank you. Yeah, it's a specific point, but just wanted to say it was a really interesting conversation, and I think it's the aim certainly going forward to try and move the committee in terms of delivery and performance into those areas, so that we're not just looking at old and historic data which tell us 3 months behind where we were, and it is going to be a change which I think has started to emerge. It's going to be difficult because the availability of data in certain areas is still a problem for us, but I think we are getting there, and those are really useful conversations. The specific point I had was around EASC, and it was in their report in terms of performance reporting and discussion about systems and combining data from various systems so that they had a clear picture of what the patient journey was. I know Carol talked about where we look at exceptions, where people have had a really poor experience, but it's just wondering, do we have access to that type of data? And how useful would it be in terms of us understanding why Powys still seems to have slipped further down the response rates in terms of the ongoing performance issues?
Yeah, Chair, I'm just wondering if Steve wants to respond to this, mainly because I know that Steve went to a meeting where they were talking about end-to-end data and which has been problematic for a while, but hoping there's a silver lining on that.
Yes, certainly. Thanks, Carol, and thanks, Mark, for the question. Yeah, in terms of end-to-end data, absolutely. The health board, we met with Welsh Ambulance recently, and we got into that very subject because I'm interested in total time from the time when a patient indicates they need an ambulance via normally that phone call, to the time the ambulance picks them up, to the time they get conveyed to hospital, potential offload time into A&E department, and then time to ultimate treatment and discharge or admission to a ward. Because we know for a lot of indicators, whether that be stroke, fracture neck of femur, they're all time sensitive and time critical for outcomes. So we're absolutely in that space, Mark, in terms of looking to join data sets up. So now at the present time, we don't hold all that data, but there's a commitment to work with him on these particular issues with Welsh Ambulance Service to do that. So I'm hoping for the next board meeting, we'll be able to bring back some, if you like, special focus areas on fracture neck of femur and stroke in particular, along with others if we can get access to the data. But definitely an area of development that we need to get into, and a really important piece of work, not only from a data perspective, but this is about outcomes and access, which then impact on planning and deployment of resources, because we need to improve that 8-minute response time. It's there for a reason, as an indicator, as a measure of good quality outcome, and so we need to get under the bonnet, so to speak, to see if there's anything more that we can do to improve that target performance.
Thank you, Steve. Just quickly then, Claire, comment?
Yes, thank you, Chair. Just finally for me, a comment in that actually Welsh Ambulance Service are now in a very different position to be able to contribute to that end-to-end data, having in the last year implemented the electronic patient care record. And prior to that, that would have been very difficult for the service to engage with other services to do that. So actually, this is really an opportunistic time now for us to work with them in that end-to-end data. But I think they're probably pushing the wider system as well to be able to utilise and draw on and be opportunistic around the fact that they've now gone to an electronic patient care records. Thank you.
Okay, thank you. Of course, you know about that, Claire, having come from there. So thank you. And Claire Marsden made a very useful comment way back, which I didn't read out, but it concerned the matter of the patient story and how useful that is as an illustration. So thank you, Claire. Right, so now we will pause the meeting and resume. I can see we're 5 minutes over, but I think we could possibly make up time later. So if you could come back, please, by, well, I think 11:50. Yeah. If Pete is ready, we'll go straight to the financial performance report for month 5. Over to you, Pete.
Yes, thank you, Chair. So the finance report is included in the pack in the usual format. As usual, I'll take us through some of the key messages and some of the key issues to pick up in the report. As I do that, I will reference the financial report page number to make it easier for members to follow. Carol's already mentioned the high level details of this in a chief exec report, but if I take you to page 2, as you can see on page 2, in relation to our revenue financial position, as of month 5, we are £2.8 million overspent. And as I mentioned earlier, we're now forecasting a year-end deficit of 7.5 million. Forecasting a deficit means that we will fail to deliver against our statutory duty to break even. Also on that page, I'll mention the capital position against our capital resource limit of 9.6 million. We've currently spent to date 2.5 million, with no major issues to escalate in relation to capital. For the rest of my report, I will focus on the revenue position. So in relation to our overspend and our forecast overspend, those key pressure areas include continuing healthcare, mainly in regard to mental health and learning disabilities. It's worth mentioning that since 2019, 2020 to this year, we've seen a growth in spend in this area of £10 million. That growth has been in relation to increased costs of packages, but in the main to the increased number of packages of care being provided. Also included is the non-delivery against our savings targets, our continued pressure against our commissioned services position, those services provided by other providers, and that's partly in relation to increased emergency activity and activity in relation to renewal and recovery, and ongoing pressures in relation to variable pay. So on back of this position, the Health Board has triggered putting ourselves into financial recovery, and as part of that, we've established the Finance and Performance Subcommittee as a subcommittee of the Executive Committee. The main key message in that area is that for all areas there needs to be a focus on reducing our current run rate, and that focus needs to be on a this year and a next year basis. If we can just take you to page 4 in the report, this gives a bit more detail in relation to our delivery of savings against the target as included in our plan. The first table gives details of the performance for 22-23. So against the target of £4.649 million, we have £2.2 million worth of green schemes, which are anticipated to deliver, £730,000 worth of amber schemes, which are targeted with further action to deliver, and a current pipeline of further schemes of 4.6 million, which are not yet worked up. So still means we have a shortfall against our target of 1.6 million. But included in this delivery, all of the actions in the main are non-recurrent, which means that target will be included in our ask and our underlying position as we move forward to next year. As you can see, against the next year recurrent impact, at the moment none of those schemes are green, and £760,000 worth for amber. So this is a key area because what it means is that any shortfall on a recurrent basis will add to our underlying position as we move into the new financial year. If we can just take you to page 9 of the report, this one isn't included in the slide deck, so I'll just want to mention this one. So just a reminder that our financial plan for this year was made up of 3 elements: the core financial plan, in which I'm reporting the variance from plan in this meeting. We also had the areas of the COVID national programme, where this is funded by Welsh Government. It's included in the table included on page 9. But we also have the ongoing COVID response costs outside of the programme areas, and exceptional cost pressure areas such as energy and fuel and the real living wage. And a reminder to the board and to all members that these areas are assumed funded by Welsh Government, and this is done on a risk share basis, and there's still a need for us as a health board to reduce those costs as far as possible, and that is a requirement and expectation for Welsh Government as we move forward. I do also need to highlight that as we move into the next financial year, we need to have a clear understanding of the impact of what this will have on our underlying financial position, and have clear exit strategies in place or clear plans to be able to meet those ongoing costs if not funded into the new year. If I can then take you on to page 10 of the report, that was the previous slide, please, Liz. This gives you a breakdown of our current forecast deficit, and it breaks that deficit down over 3 key areas. So we've got those areas where we've got a variance against our plan. That means that we're not delivering the actions that we had put into our assumptions regarding our financial plan linked to our IMTP. And they include some of the areas I just referenced: non-delivery of the savings target in full, not managing to mitigate the growth in CHC cases, and some additional pressure around recovery and renewals, and a commissioning position, as I mentioned, and that accounts to 5.4 million of that forecast deficit. The way we then have new pressures included in our position, they include the continuing growth in our continuing healthcare, increase emergency activity in relation to Wye Valley, some additional costs in relation to mental health private providers, which has been needed due to needing additional capacity than what we can provide ourselves, and some other increased cost pressures around the Welsh Risk Pool and EASC. And then also included are some opportunity areas to net down that total 10.5 million forecast pressure to give the forecast deficit of 7.5 million. as I just take you through then, so what the other important point to note is that the current position and the forecast deficit of 7.5 million does include some other non-recurrent opportunities. And at the moment, as we move forward into the new year, we're looking at an ask of around 15 million as a deficit position to make up. So every action we take in this year will help to reduce that forecast deficit, which is urgent and needed, but also would then lead to an improvement in our starting position, our underlying position for 23-24. So there's a sort of a double win and a double impact in terms of that regard. As I mentioned, that urgent action focus has been increased in relation to the Financial and Performance Exec Subcommittee. So just really to give a summary before, and this is on page 11 of the report, before we get into a wider discussion and comments. The key message is that we're £2.8 million over against revenue as at month 5, with a forecast deficit of 7.5 million. And included in our month 5 position is £2.25 million of non-recurrent opportunities. Our key pressure areas, as mentioned, include our CHC position and the significant growth we've seen in number of packages of care, variable pay, our commissioned services, and our non-achievement of our savings target. And to note the impact this has on our underlying position and opening deficit as we move into 23-24. So it's an area needing urgent focus and attention, an area that needs the full attention and action of the full board and the full organisation, and for everyone responsible for committing expenditure. I'll pause there, Chair. Happy to take any questions and to open up the debate.
Right, questions. Robert first, I think.
Thank you, Chair. A general question, really. So it could be to Pete or the CEO about the processes that we as a board will need to go through in the next 6 months in order to come to a sort of judgment, really, a balance of our responsibilities. On the one hand, we would very much like to reduce any deficit. On the other hand, our existing and perhaps increasing obligation, if there is the resources available elsewhere, to treat even more patients and to help in the recovery. Thank you.
Right.
Did you want me to go first or Carol?
Yeah, well,
yes.
So, go first and Carol.
Yeah, thank you, Robert. I think at this point it's worth reminding ourselves that our total spend for our population is circa 360 million. And I think in all that we do, we need to focus on making sure that we allocate that resource into the best place to deliver those best outcomes. You make a very important point there, Robert, in terms of we will face choices and decisions to make as a board in terms of priorities. And those priorities will always be about maximising the care and the outcomes for our population. And I think as we move through this, we just need to be clear as a board in terms of what those decision points are, what the implications are, what the financial consequences are, and what the outcomes are. I think that's just a short reply for me, and I'll pass on to Carol.
Yeah, thanks very much, Pete. Thanks, Robert. So I referred earlier to the planning phase that we're going through now in terms of Q3 for the next 3 years. I think it's going to be really important as a board that we understand, as Pete said, how best we allocate the £360 million that is available to us to improve the health of the population, understand what choices that we may need to make, the options are around that, and to understand the impacts of that and have those discussions openly with staff, clinicians and other stakeholders. It's difficult to escape some of the wider economic challenges the country's going through at the moment, and so I guess there's quite an uncertain outlook in relation to public sector investment and expenditure, and what the medium term might look like, or even to some extent, Robert, the short term. So we will be keeping a very close eye on what that looks like and linking very closely with Welsh Government so that we can set the appropriate parameters for our planning. Often we don't actually get confirmation of our funding until the third week of December. We won't be able to wait that long. We have to work on some different financial planning assumptions and outlooks. But as everyone knows around this board table, it is a very serious matter for us to ensure that we can balance the duties that we have in relation to finance and the public purse and the provision of really good care to people. I think the big question for us is, are we as efficient and as effective as we should be before we start making what might be some difficult choices? So that's some of the question that we'll be working through, particularly as an exec team, and it links to the item earlier that Steve presented on performance, how we deploy our resources and what we get from that. So there's quite a bit in there, Robert, I think, for us to have to work through as a board over the next 8 to 12 weeks at least.
Yes, I think we're all well aware how serious it is. I think Mark was next. Yes, but could you put your question, please, Mark?
Thank you, Chair. Yeah, it's slightly away from the main topic to Appendix 2, which is around the capital. And I know Pete said there was nothing to escalate on capital, but you've got the table there, which shows we're about £3 million through the £10 million spend. And I just wanted to get some further indication that we're on profile for that. I know the spend is going to increase rapidly by the nature of the construction, but it just starts me looking at it saying, are we far enough forward on that? And the real concern for me is, if any slippage results there, will it impact even further on the limited discretionary capital we'll have going forward into next year?
Yeah, thank you, Mark. It's a good point and a good question, and often we see this a little bit of a disparity between the capital profile to date and the actual position, and a lot of that's linked to the work in progress and when we trigger the payments in that regard. So the finance team linking with the capital team and members of Jamie's team, they're always reconciling this, they're always tracking the progress, and if at any point there was any concern that there would be slippage or pressure, that will be escalated and discussed via the appropriate mechanisms. Yeah, I'm not sure if Jamie would like to add any further comment to that, but at this point it's not a place that anything needs to be escalated.
No, I think thanks for that question, Mark. I think it fares to Pete. He answered the question before I did in the way I would have said so, which is that it's a constant process of monitoring that. We work always to ensure that our capital schemes are done on time and we maximise the benefit of the money. So there's nothing to escalate at this stage, but it is a continual daily process to ensure we maintain that positive position, Mark.
Okay, thanks. And the point about the impact, if any, of slippage on the discretionary capital?
So Mark, you're right. If there is any slippage or any overspend, that is something then that we have to look at managing across the year, and there is a potential impact. But as said, at the moment there's nothing to escalate, and as in previous years we've been able to manage that position fairly effectively with not having any sort of significant issues. If there are any, they will be escalated as appropriate.
Thank you, Pete.
Thank you.
Claire Roach, you've got a comment.
Sorry, yes, thank you, Chair. I think it would be remiss of me, given the context of, obviously we've noted in this report the high levels of variable pay and agency usage, and colleagues may have noted this morning on the news, the Royal College of Nursing have published their annual report into nurse vacancies. And across the whole of NHS Wales, there has been an increase in 41% in agency spend between 21 to 22, and there has been a 69% increase in nurse vacancies across Wales from 1,719 to 2,900. Now, I haven't had a chance because that was published this morning, and obviously we've had boards a day to read that report in detail, but those were some of the high level messages. And just to say that in addition to the work that I'm involved with internally in the organisation to be able to look at levels of nurse vacancies, as a group of executive nurse directors working in partnership with the workforce directors in Wales and HEIW and the Chief Nursing Officer, then that move to a sustainable permanent workforce is really high on the agenda nationally. So I think it is important that we recognise the context as a whole nation and indeed the UK. Thank you.
Thank you, Claire. Right. So Ian, you're next, I think, with a question.
Yeah, thanks very much. Pete, I just wanted to ask a question. I mean, you quite rightly talk about our overall budget, 300 million or so, whatever it is, but I'm just mindful of the fact that a lot of our costs are fixed. You've mentioned in the past block contract arrangements being in place in Wales still. So I just wanted to try and get a feel for the scale of the problem in terms of our ability to move money, or where that isn't possible, rather than see it as a 300 million pound problem. It's probably worse than that, isn't it? Because a lot of our costs are either fixed for ourselves or tied up in other contracts.
Yeah, thanks, Ian. So it's worth reminding that our English contract arrangements are PBR, so they are linked to activity and can be immediately recognised. In Wales, it's been based on a LTA arrangement with any sort of increase or decrease in activity being recognised at a marginal rate. For this financial year and currently this year only, there is a tolerance has been agreed that's around 90%, with a level of under and over performance recognised above and below that rate. So it's not a pure block position. Based on our current performance, the impact of that isn't hugely material. And what I would say in response to that is that if we focus on absolutely doing the right thing, putting our resources in the right way, if there are any financial barriers to enable us to do that, that we still try and do the right thing, and we work with partner organisations to find a way to make that work in the best way. You are right, though, in terms of where our resources are committed, but I think, as Carol said, we don't know that we're not 100% efficient. We do know that there's areas of opportunity, and it's focusing on those areas of opportunity to do what we can and being realistic about that.
Yeah. Katie Blackburn, you have a request to make an observation.
Yeah, I mean, clearly challenging times, not unique to Powys, but I've had initial conversations with Steve and Hayley, but obviously there may come a point where decisions will be taken by the board about perhaps potentially changing services or whatever, and it's just to record really that just to keep the CHC in the loop with any discussions that you might be having, really.
Yes, thank you. I'm sure that will happen. Right, well, I don't know whether we've got to the end of this discussion. It's clearly going to be an ongoing issue, Pete. Did you want to finish that section off, Carol, by any comments? Or I think Pete has made the position very clear, so.
Just to say, you know, that we will, in this public forum, be outlining the actions and the considerations that we need to take as a board. And just to pick up on Katie's comments, you know, that stakeholder discussion, I think, Katie, would be really helpful. We're signalling some very choppy waters financially at this stage. In this public domain, people will, I hope, through the whole of this meeting, understand some of the challenges we're grappling with, and as a public sector body, we're going to have to work through those with people. So welcome those comments, and thanks very much, Chair. There will be more on this at our next board meeting.
Right, thank you very much. Thank you, Pete. It's very, again, I would say, very clearly presented, very easy to understand, so thank you. Shall we move on then to winter planning? Steve, again.
Thank you, Chair. So we are now at section 194 of the board pack, and there's a 6-page covering paper that we've written to support a 31-page winter plan. So both documents are in the board papers. In terms of the winter plan itself and the covering paper, so we've not had a formal request as yet from Welsh Government to submit an actual winter plan to Welsh Government, unlike previous years. But since this report was written, a communication has come out to say that winter plans are required to be submitted to board and regional partnership board for review, noting and approval. So that's the context by which this report has been produced. The covering paper alludes to 5 priorities that we've identified, and that's around the 6 goals of urgent and emergency care, and really how that system at large needs to function effectively, not only to produce that timely access for patients, but really if that component is not functioning properly, there'll be a direct consequence on the delivery of planned care, volumes of activity as well. So that you know, we really do need that component of the health system to be fully functioning. As we've heard earlier, it's not at present. So there's a lot of effort going into the winter plan, not only ours, but the wider Health Board and English Trust partners, to do everything we can to improve urgent and emergency care. We've also included some areas around primary care and accelerated cluster development, acknowledging, you know, primary care is a really important role across the winter period, as it is across the whole year, by the way, but particularly so across the winter period, and alternatives around signposting and so on for patients where appropriate. Vaccination and public health plays a role in our winter plans. We've included some information on that, and we've also the majority of the plan is around system capacity and system working relationships around social care, independent sector, community third sector, and also for our commission services with our partners. We've also touched upon the resilience and business continuity that we would need to be mindful of across the winter plan. The winter plan itself, the PowerPoint presentation, it picks up on a number of known factors. So the pressure in the system that we've already articulated, the fact that we're quite a complex organisation in terms of who we commission and provide with, but we've also drawn out some new factors that are becoming evident both this year in terms of the cost of living increase, the energy crisis and supply and distribution and sustainability of that. The COVID-19 pandemic is still with us, and also you know, there's workforce constraints not only within the health board but also within the partners that we deliver services with. In terms of any good plan, we're keen on the measurement of expected benefits. No point having a plan if we're not routinely reporting on it correctly. And so on page 4 of the PowerPoint presentation, we've spelt out early on what our expected benefits are. So we want to maintain a clear focus on patient safety in order to one of the backbone components of our winter plan is that we reduce our length of stay in our own community hospitals, so that we create headroom if we need it to surge capacity, to take some of the pressure off our acute partners, that we seek to minimise discharge and any delays on transfer, that our repatriations are kept to an absolute minimum in terms of delays, and that we're sustainable, and that we are able to track changes across our partners and respond quickly to them. So communication and frequency of meetings to review system cohesion and system performance will be key, and that's building on some of the learning that we observed last winter when we conducted a similar exercise. We were successful then in preventing surge capacity through that proactive look at data and information, at surge, at flow, and take appropriate steps. And it touches on those leading indicators we talked about earlier, and getting a real handle on both the volume of patients being admitted into hospitals and the likely timescale that they will come back into Paris and we need to respond. So we've got a much better handle on that now than previous. And so those expected benefits we will be monitoring quite closely on a weekly and some on a daily basis, so that we can be sort of fleet of foot, if you like, in terms of delivery of a winter plan. We have included some risks in our plan, because obviously we've got workforce challenges, we've got flow challenges, so it would be remiss of me not to point out the risks across the period. I will pause there, Chair.
Right. Are there any questions at this point? It's good that you're ahead of the game, Steve, in that you at least anticipated that this would happen. So I can't see. Carol, would you like a comment then?
Yeah, sorry, Chair. I can see that Mark, I think, wanted to come in.
Yes, I've just seen him now. Yes, this minute. Sorry. Mark, please come in.
Thank you, Chair. Sorry, trying to get the mute button to work. Two questions, if I could. The first, not necessarily in terms of the winter plan, but just looking at the slide relating to primary care. We've looked at the issue in terms of sickness absence previously in committee, and this to me seems that it's going in the wrong direction from when we looked at that. And those rates of sickness absence are quite significant, and wondering if there's a workforce sort of action that we might be able to take, because I know that individual practices may be having trouble in terms of recruiting locums, etc. And I think it goes back to Richard's earlier point about availability, in terms of being able to have our own sort of floating pool of staff that may be able to help and support around that, because at the moment those trends seem to be going the wrong way and likely to get worse. So that was the first question. And the second one was about, there didn't seem to be any finance or resourcing element to the plan. I think the plan was very strong in terms of its presentation and getting the right priorities, but for me it was where's the costings and resourcing. Thank you.
Steve? Oh, Carol, yeah.
Yeah, thanks. I just wonder if I jump in now on the cost and the money. In most winter periods, Welsh Government have identified a certain amount of money for the winter. That isn't the case this year. But importantly, the regional partnership board, and Steve mentioned this, and the requirement for the regional partnership board to be involved and to see the planning coming through, has got regional investment funding, and so there have been some discussions on releasing some of that money to contribute towards the winter. Now, I don't want us all to get very excited on that, because it isn't a significant amount of money, but I think it brings into question how we work across the partners to devote sufficient resource to reducing the risk and improving outcomes. We have to think in a very different way, and so I hope moving forward that the work with the regional partnership board in particular and our partners can mean that we deliver something different. But Mark, there isn't a pot, and I know you'd have remembered previously money being allocated by Welsh Government. That's not the case this year. We're expected to deliver this within the resources we have available to us. Sorry, I've forgotten the second part of your question, Mark.
It was relating to whether we could look at some intervention from a workforce perspective to support the sickness absence in primary care.
Yeah. Hayley might want to comment on the absences, because I know that certainly during the pandemic we were finding that often it was some of the administration and support functions in particular that were under pressure. So yeah, if I can bring Hayley into that one, she'd be best placed to respond.
Thank you, Carol. It's a really important point, Mark, and I think that it is the case, particularly with the size of our practices as well, that the sickness rates in percentage terms that have been very high and above the Welsh average at key times throughout the pandemic. And most recently, we monitor on a weekly basis and have active discussions with each of the practices on their workforce challenges. And I guess there are three elements around this. So in terms of the recruitment challenge that we're all facing generally in the NHS, we are having discussions about how we support some of that shared endeavour as a health board with practices around recruitment. So for example, some of the open days that we've held, we're looking at all opportunities across the system, whether that's health board directly available posts, or actually making sure people are aware of the vacancies in the primary care sector as well. Attended a big affair in Birmingham over the weekend, trying to attract people in, and there's further work at a cluster level, the GP collaborative at a cluster level, looking at workforce issues, challenges, and also potentially opportunities, thinking much more in partnership across several practices rather than at an individual practice level. I think your particular point about what's our role and offer there, I know that we're having active discussions at the moment, Richard, Kate and others, around a couple of areas in particular, and also we're exploring about supporting practices where they need to actually have sponsorship licenses for staff as well. So there are opportunities there as well. And in relation to education and training, we have always had quite a strong offer in terms of ongoing education, training and development in primary care, but I think that will strengthen due to the additional national drive around establishing the primary care academies, which will form part of our health and care academy. So what I would say, Mark, is that there are a number of areas here, a number of strands of work. Whether that will result in us having a sort of a pooled approach and our opportunity to support as a health board, I think everything's on the table at the moment in terms of looking at all of the options available.
Right. I'm happy with that response, Mark.
Yeah, I think in part, obviously, it's concerning, and the one aspect I just wanted to explore, I understand now that the funding essentially is probably coming from our bottom line in terms of that delivery, and like previous years, I'm just wondering how we are going to cost and present this going forward. So even though it's coming from our resources, what is going to be the cost and the sort of scale of what we need to commit in terms of that delivery?
We can do a follow-up piece, I think, Chair, for the Delivery and Performance Committee, just to see where do the resources come from for these actions, because we are drawing on resources from different parts of the system to help on this.
Yes, that would be helpful, thank you. Kirsty has a question.
Thank you. Understandably, vaccination and public health form a very important part of the plan for both citizens and crucially for our staff. But Stephen, if we go back to the data in the report that you've previously presented, sometimes we have struggled on staff vaccination in particular. And there seems to, certainly in the last 12 months, been a drop off with pregnant women who've chosen to take up the vaccine. And I wonder as well, there's some anecdotal evidence floating around vaccine hesitation with regards to the latest booster programme for COVID. And I'm just wondering about what sits below this plan or this statement about vaccination to ensure that our staff take-up is maximised, as well as whether we have any indication at the moment that there is any vaccine hesitancy with regards to COVID. I was very fortunate to visit both Bronchlis and Llandrindod on the day of the Queen's funeral. Vaccination centres very busy, doing a brisk trade, which was very welcome. And I'm just wondering whether we are being able to buck the trend of any vaccine hesitancy with regards to COVID.
Thank you, Kirsty, for that question. I'll probably let Mez respond to those if that's okay. Thanks, Mez.
Yeah, happy to. Yeah, so and thank you, Kirsty, for visiting the centres as well. So I know that's appreciated by staff. So as you say, vaccination going into the winter is one of our key, defence, particularly launched yesterday around flu and COVID national promotion, which we also will promote locally. To answer your specific questions about staff, I think it'd be fair to say that our staff uptake has been lower over the last sort of year or two. Some of that is contributed to changes from working from home, and so forth. So we have changed it this autumn that there will be a systematic invitation for all staff to attend for vaccination at the mass vac centres, and then followed with mobile teams to offer, a vaccination then at ward, etc., for those staff that have been unable to attend the centres. So how we offer the vaccination to staff, we're adapting that for this autumn to look at how we can improve uptake there, and we will also be then doing obviously promotion and encouraging staff to get vaccinated as the best defence that we have. Early indications from our COVID vaccination, sort of pleased really that the programme commenced on 1st of September this year, and the programme focused on care homes for older adults sort of initially, and the immunosuppressed individuals who fall into immunosuppressed sort of groups. And so far from the groups that have been invited to the MVC, uptake is good, but it is early days and we're monitoring that, and we're not seem to be seeing the hesitancy in our population as yet, but we will be monitoring that very closely, and we do have strategies that we know that work around vaccination, around invitation, re-invitation. And then we're also engaged with GP practices that the majority are offering COVID vaccination as well, which hopefully will help in terms of the older age groups and in terms of less travel to be able to attend the local practices. So I hope that's helpful to answer your question, but just to reinforce, it is a key strand going into autumn, and it's important really that we promote at every opportunity.
Okay, thank you. Are there any more? We will need to press on. I have one question about the potential for industrial action by nurses. I don't know if there's any clarity around that at the moment, but every time it's raised in the media, it seems to be a highly likely contingency that would have to be taken into account. Obviously, what I would want to know is how that might affect, this plan. You can't really plan when you don't know anything for sure. Carol?
Yeah, just to say I have had notification from the Royal College of Nursing regarding balloting of members. In discussion with the Director General and the NHS Wales Chief Exec last week, a group of us as Chief Execs discussed the winter and raised that issue. We will be working collectively on the scenarios that may occur in relation to any potential industrial action, what that looks like. You know, whilst the Royal College of Nursing have signalled that intent, I think we're wise to consider if other unions also would take that action, what that impact might be. But yeah, thanks very much, Chair, for raising that. That is a key issue.
Okay, thank you. Well, I think we've had a good discussion about that, and it's good to see that a lot of work has been done, and I wish you well with it all. And thank you, Stephen, for your hard work. Could we then move on to look at the risk and assurance section, agenda item 3.4, and over to you, James, please.
Thank you, Chair. I'll assume the cover paper explains a lot, and the paper has been read, and just pull out some key points, if I may.
Thank you.
So we've recast the risk register as a result of some discussions the board has all been involved in over recent months. As you will see, there's a change with regard to structure in terms of introducing inherent risks, whereas we were previously recording initial risk, which I think gives a better demonstration with regard to the various stratification of the risk, and so you can see the impact of the actions being undertaken against the inherent risks, which can of course change, whereas initial risk can't. So that shows the more dynamic nature of risk that we're reporting against, and hopefully the board will see, you know, a strong dynamic and a strong link to a number of the other items that have been discussed today, and really through a risk lens, looking at, you know, where that could go if we're not taking effective action as a health board. So hopefully it's really focusing on the main strategic and significant risks, and we'll continue with the usual processes with regard to organisational management and escalation if required through to the corporate risk register, and we'll continue to develop the register itself and the underlying processes in the committees as well as referred to earlier.
Thank you, James. Are there any questions? Observations? Again, it is very clear, and it's something that we have discussed. So Ian has a question.
Yes, thanks, Chair, and thanks, James. I just wanted to reflect back on some of the comments earlier on, and pick up something in the minutes with regard to clinical information and record keeping, which you considered, and I guess my ongoing concern that it's not seen as a, to use your word, strategic or significant risk. For me, still, I have to say that the lack of an integrated contemporaneous record, the fact that clinical information is stored in a variety of places. We had the conversation earlier where it's both electronic and paper-based. The fact that different pieces of information exist in many different places, that's a particular problem for us in Powys due to our geography. I think I'm just concerned. We've got the fact that our estate, for example, in CRR 10 is a risk for us. I think our information estate is equally a risk. So I guess my concern and disappointment that strategically we didn't see this as a strategic and significant risk. And I think for me as well, slight concerns around the fact that it's not reflected here, bearing in mind that it's a key enabler in our health and care strategy to work to this as part of the Digital First programme. So yeah, and I guess reflecting also on my previous comments in terms of double entry for staff, at a time where we've got workforce shortages, but for some time to come, it is highly likely the folk will have to continue to use multiple systems, paper, multiple electronic systems, and the fact really that what we need to be striving for is a patient-based record rather than a departmental or service-based record. Now that is a very long-term thing, but I do see it as a strategic and significant risk, and one that we needs our ongoing attention.
Carol, would you like to respond?
Yeah, thanks very much. Pete might want to say something as well on this. I think there's a couple of aspects there for me, Ian. CRR 002, although it's got a label of finance, this is about how do we properly allocate resources to achieve our objectives. That's what that one really is, if I put it in simple language. And I think there's something in there about are we putting the resources in the right place around some of the challenges we've got around digital transformation as well. Now, I know we've made some steps forward, but it may be that we need to illuminate that a little bit more under some of that. And you know, I think Pete referred earlier, or maybe it was in a meeting yesterday, to DPIF, which is Digital Investment Fund from government. You know, we've managed to secure quite a lot of resource from that fund to make those changes. I think for us, laying out more clearly what's that path to those changes and what impacts will that bring when we're looking forward and planning. I think that might be quite helpful, Ian, in taking your points forward a little bit more. We have got a session in October as a board to get underneath the digital first agenda. And I think at that point we may, because of course the risk register is a live document, you know, we can add things, take them off. We can take some, you know, sort of soundings on where we think we are really on that once we sort of get into some of the detail on that, Ian. So I think we've still got to see digital as an enabler when we're talking about this significant workforce challenges that we've got. So whether that's digitisation or whether it's something even more substantial than that, whatever we can put in place to support people to deliver services more efficiently, we need to do. So hopefully that helps for us to come back to some of those discussions.
If I may come back just briefly, that was helpful, and I appreciate that CRR 02 in terms of appropriate allocation resources is part of it. I think the only thing I perhaps would push back a little bit on is the fact that digital may be the answer, but it's not. The lack of investment may be a risk for us, as so many other areas are, but I think the risk is a clinical one in terms of the lack of a contemporaneous and full record. So that's the only thing I'd perhaps push back a little bit for consideration by the executives.
Yeah. Chair, I'm sure we can explore that one and understand the current position and what that looks like in the October session. So happy to pull that out specifically.
Thank you. And did Pete want to respond to that, or are you happy with that answer, Ian?
Yes, I'm happy with that answer. Okay. Thank you very much.
All right, thank you. Shall we press on then? Katie's report as Chief Officer of the Community Health Council.
Thank you very much, Chair. I'll be as quick as I can, but I'm very aware that a lot of the discussions today, I've been very tempted to sort of make comments and observations because I think some of them are really quite pertinent to some of the work that we've been doing, which I'm going to share with you today. Obviously, you've got my report, but I just thought I'd particularly pick out a number of other pieces of work that's going on, which I hope you might find useful and interesting. We've obviously, as a CHC movement, got a variety of ways that we listen to patients and communities. And what we've done over the last couple of months is we've adopted an approach where we have a question of the month. We put that on social media for a week, and we've done people's experiences of dentists accessing dental services, and the second one was people's experiences of accessing GP. We're about to do people's experiences of accessing WAST services, and future ones will be people's experiences of waiting times and people's experiences of eye care services. We hear, all of us, a lot of anecdotal evidence, but this has actually been really interesting and really useful. And we only open it for a week and we get about 200 responses, so it's really raw data. So we're sharing that information with you at the Health Board. Another piece of work excuse me, that we've been doing is that given the pressures on primary care, particularly GPs at the moment, and the need for patients to be getting the right service at the right time, one of my team and two of my members have independently, against a set of agreed questions, reviewed all the GP websites in Powys to see how easily accessible information is, and that could range from contact details, whether there's a map, whether you can cancel via the website, whether you can make a complaint, whether putting things right is mentioned, whether the CHC is mentioned, and what the opening hours are. And it's really quite detailed, and a lot of websites have that, but the other question is, how easy was it to find it? So that piece of work we will be sharing with you, but included in that is around signposting and accessibility. From a sort of strategic potential change perspective, Carol's already referred to the Wye Valley Trust and potential changes to stroke services, potentially moving services from Hereford to Worcester. So we're engaged with that. And Carol has also mentioned the situation with the Wales Air Ambulance, and although the Wales Air Ambulance itself is a charity and therefore not governed by the regulations, the services that are commissioned from the Wales Air Ambulance by EASC are, and therefore I've had a number of meetings, as I know Carol has, with Stephen and Harry from EASC, and indeed with the Wales Air Ambulance itself. From our perspective, you know, we're looking forward to seeing the more detailed data that Carol referred to earlier. But from our perspective as well, there's a real issue around communication and engagement, and a real urgency to do that. This is an all Wales strategy, but there's clearly a significant amount of noise in Welshpool, and there's the communication strategy is, as stressed, Stephen came to our services planning meeting this week, is really urgent. It's not helped by the fact that the WAST response times in Mid Wales are very poor at the moment. We've talked about that today, and therefore there's a misconception that Wales Air Ambulance are sort of subsidising that service. So it's all interlinked, and you know, that community needs to be communicated with. I'm hoping that a draft communication plan is imminent this week, and myself and a number of the senior directors of the Health Board are meeting next Tuesday to work our way through that. We're hoping to go back into visiting hospitals. I've already mentioned about you know, the need to sort of get back to face-to-face. GP surgeries are quite empty at the moment, but we're putting a session in to go up to South to look at maternity up there, and I'll have a chat with colleagues about what else we could possibly do. We've got some ideas, but I'd like to share it with them first. Obviously, from the point of view of publishing, we just finally had it translated, the pharmacy report, which we've had a response from you, from the Health Board. The dentist question of the month is about to be published. I think one of the questions perhaps is, how do we share that with independent members and members of the board, whether those reports just come to patient experience or whatever. I think there's a lot of really good stuff in those reports that I think might be quite useful, just to help inform thinking. I've nearly finished. We've got the Citizens' Voice body launching on the 1st of March. Just to let everybody know, I think people probably know that the board has now been appointed through the public appointments process, and 2 weeks ago, or was it last week, the confirmation of the appointment of the Chief Executive Officer, who will be Alison Thomas, who is currently the Chief Executive of the CHC. That will be on a one-year interim basis to manage through the change. And both Medwyn Hughes and Alison Thomas are joining the Powys CHC next Tuesday to have discussions and chats. Finally, I must just say thank you to Viv as well. and wish you all the very best for the future, Viv. I've really, and I'm sure David has, and I know Francis did as well, really appreciated our 6 weekly meetings. Been quite challenging at times, and that's how it should be, but we're really grateful for you giving us your time and for the commitment that you as a health board and yourself personally have made to the importance of the Community Health Council. So on behalf of all of us, all the very best for the future.
Thank you, Katie. It's been a pleasure to work with you. Thank you. I know Carol wants to respond to your some of the issues you've raised. You know, we are well aware of the some of the problems with what you have mentioned. Carol, would you like to come in?
Yeah, thanks very much. You know, if I could firstly say, I really like the sound of question of the month. Interestingly, we know that they're on topics that are issues. So it'll be interesting to see whether we learn a lot of new things about that. But I in particular just wanted to pick up the EMIRTS service, and we've touched on it a couple of times. So it's to be very clear about the role that we have as a health board, as a commissioner of this service via EASC. And you're absolutely right. The Chief Ambulance Services Commissioner is taking that coordinating role, and we'll be meeting regularly with me and my team in navigating this process. The most important thing is to get the data understood, and because there may not be an issue that people are very very worried about. So getting that understood, getting that out there, and then we can all get to a position on it. So I'm hoping that if anyone is sort of tuning in live or afterwards on this meeting, that the fact that we've touched on this a number of times is reassuring in terms of we're hearing the concern. Let's get the data and understand what that really means for residents of Powys. But yeah, that was the only thing I wanted to pick up on, really, Katie. So thank you very much for the report.
Thank you, Katie. Right, now the assurance reports of the board committees. I think, Carol, if you go first, we do have some items for ratification in your report. I think the other reports probably can be treated as having been read, but there may be 1 or 2 points people want to pick up. So off you go, Carol.
Yeah, thank you very much. Hopefully board members found the exec committee chair's report useful. It gives a very detailed account of all the business that we've been covering. As you say, though, Chair, there's a couple of things that I would particularly request. Important to recognise the work that's been going on in relation to the cybersecurity incident, in relation to the Adastra system, the out-of-hours system. That has been an ongoing incident. I'm assured by the mechanisms that have been put in place and have been tested and retested, and would like the board to endorse the steps that we have taken in terms of additional measures and support in relation to that. The second one is the board will recall that we looked at the satellite radiotherapy unit business case, which was a business case developed by Velindre Health University NHS Trust and health boards in collaboration, and just to reiterate our endorsement of that business case moving forward. And I think that was particularly drawn through as we enter into the next planning round. Now, this is very important for our population because they'll be able to access services closer to home in the south. So wanted to endorse that. The agreement that we transfer the local public health team function from Public Health Wales to the Health Board, that item was considered earlier this week by the Audit Committee yesterday. We're looking for endorsement on that. And then the final endorsement is the committee's agreement to providing an inflationary uplift for providers in relation to continuing healthcare of up to 8%, noting that there is a financial impact here of approximately £300,000. However, I think this case absolutely illustrates the challenges of provision of care in what is an inflationary environment at the moment. So some particular challenges there. So those 4 areas, Chair, and I've got directors who are able to clarify those points if needed.
Would anyone like to ask a question about any of those points? I don't think they're matters we don't know about already, but Robert.
Yeah, just a quick question. So on the Velindre satellite, are there financial implications for us? I couldn't remember if that's the case. And the second thing is chemo obviously not part of the radiotherapy section? Is plans also to formally provide those services going on as well?
Yeah, thanks very much, Robert. In terms, and Steve might come in on this, in terms of the financial implications, I think there is some implication, but it is small. My memory is telling me it's in around the £20,000 mark. Steve's nodding.
Correct.
That's great. And in terms of chemotherapy provision, this is one of those areas which, under our cancer programme, we are interested in exploring what could be done closer to home, and particularly around ambulatory care. So although you're absolutely right, it's not specifically in the radiology case here, there is that broader context of cancer services and the provision at home. Unless, Steve, you want to add anything else or clarify what I've said.
No, Carol, thank you.
Okay, thank you. Happy with that, Robert? Okay. I'm assuming so. Thank you. Oh yeah, I can see your hand. Right, so are there any other questions before we look to endorse these? Okay, just take the first one. Are you happy to endorse the steps taken to limit the impact of the cybersecurity incident on the Ad Astra system and monitor progress? Yes, everyone, thank you. Are you happy to endorse the Executive Committee's ongoing support for the satellite radiotherapy unit at Neville Hall Hospital and the wider integrated radiotherapy solution? Everyone happy? Thank you. And then are you content to endorse that the board, that the Executive Committee's agreement to transfer the local public health team function, staff and resources to the Health Board from Public Health Wales, subject to clarifications? Everyone happy to endorse that one? Yeah. And finally, is everybody content to endorse the committee's agreement to provide inflationary uplift for continuing healthcare of up to 8%, noting the impact financially? Yeah. Thank you. I can't hear any dissenting voices, so I'm assuming that you're all happy with endorsing all of those. Thank you. And we have just a few minutes left. So can we go through the committee reports? Mark, audit, risk insurance. Was there anything you wanted to draw out, or can we take it as read?
Thank you, Chair. No, I'm quite happy to take it as read, not least of which it was back on the 18th of July. So we had the last one yesterday. So
yeah, exactly.
That's more timely anyway.
Right, okay. And delivery and performance, that's you as well, Mark.
Thank you, Chair. No, nothing specific, but I think just noting the good progress that the report earlier on has actually confirmed about how we are changing that performance monitoring management, and hopefully to be more performance driven in terms of changing those services. Thank you.
That's great, thank you. Kirsty, Patient Experience Quality and Safety Committee.
Nothing to add that isn't already included in the paper.
Right, thank you. Robert, Planning Partnerships and Population Health.
I just wanted to highlight, in following on from our discussion of finance earlier, just to remind people that the Regional Integrated Care Fund this will be match funded in the future, so we will have some decisions to make as part of our planning cycle on what we spend and what we don't spend. Thank you.
Okay, thank you. Joint committee activity, Carol?
Yes, I didn't have anything to draw out specifically to the board's attention that I haven't already drawn out, Chair, so thank you.
That's fine, thank you. So all of that is covered. And then the assurance report of the partnership arrangements, Carol.
Yeah, again, nothing that I haven't drawn out already on that element. Clearly, importantly, Kathy Poynton is the co-chair of the local partnership forum, the staff forum. So if I could just check with Kathy that whether there was anything that she wanted to raise.
Not at this time, Carol. I think we're fine.
Thanks, Kathy. Thank you. Thanks, Chair.
Thank you, Carol. So there are no other items for information. Is there any other urgent business, please? No, so that means we are closing the meeting at 1 o'clock exactly, which is my aim every time, and I'm delighted to be able to do it this last time. So I'm sorry if I rushed you through that last part of the agenda. The next meeting will be on the 30th of November 2022 via Teams. So thank you, everybody, and thank you so much for all you do. I'm very sad to be leaving you. But looking forward to doing different things and doing things differently. And very good luck to you all. So it's a sad day for me, but goodbye, everybody.
Thank you very much, Chair.